Welcome, Ellen.
Thanks, Emma. That's a very kind introduction. And welcome, everybody. Thank you for giving up your lunch break on this Tuesday and to the BSLM team for supporting me to get this out at relatively short notice in order, like Emma said, to support us with this rollout of particularly Mounjaro that we might be seeing. But before we start, I'd be really keen to hear from people on this call, because I know many of you on the webinar probably have a huge degree of experience and lots of thoughts and opinions on our current approach to obesity in the NHS. So for those of you who are not used to this interactive format, if you go to menti.com, it's actually very, very easy. Just pop in that code 42686525, or just use the QR code and share some words, some thoughts about what you think our current approach is, whether you think we're going to be successful, whether we're actually trailblazing in terms of our approach compared to perhaps the US. It'd be great to hear from you. Great to see some thoughts around public health and bringing up this hot topic word for prevention. Fabulous. Thank you for sharing. While this talk's going on, we're really keen for you to keep sharing your thoughts, and in the chat and the Q&A, I'm going to try very hard to have lots of time at the end. We really want to hear from you about the sort of support that you'd like to have from us and what you think's going on at the moment. Underfunded, yes, that's a really big one. I think everything is underfunded, isn't it? But particularly the area of obesity medicine. And these new medicines have finally meant that some attention is being given, but I think we need to be cautious as we're going to go through. So thank you for sharing those. Keep sharing if you need more time, but I do want to ask some other more specific questions. Fabulous, really interesting. So the next questions on the same Menti code is asking how confident you feel in supporting people to lose weight and achieve better health. And I know these are enlightened audiences in terms of probably lifestyle medicine training, but it'd be great to hear how confident you feel around obesity management. And then this issue about malnutrition and obesity, which I'm going to cover today. I'd like to hear whether you feel confident to pick this up, assess people and treat this issue of malnutrition in people with BMIs in the obese range, and what your thoughts are about weight loss medicines like tirzepatide, Mounjaro, the dual GLP-1 GIP agent, and whether you feel that overall they're going to result in improved health outcomes in real-world settings. So the trial data has been very impressive. How are you feeling about rolling these out in a real-world setting? Super. So great to hear that many of you on this webinar feel relatively confident actually to support people to lose weight and achieve better health. And I'm hoping that might reflect some of the work that has been done through the BSLM. And in terms of confidence about detecting and assessing and treating malnutrition obesity, interesting that people are perhaps a bit less confident about that. So useful then that we are going to cover that today. And then in terms of whether you feel that it's likely to result in improved health outcomes, feels that we're sort of sitting in the middle, but more maybe towards agreeing that they are likely to result in improved health outcomes. So do keep filling this in if you haven't had a chance to properly. We're very interested to hear how you're feeling about this rollout and the practicalities of it. Thank you. Really, really interesting. And I hope this is going to be useful. So just brief disclosures about my work. I do some consultancy work with the NHS, but don't receive funds from any genomic tech or pharma. And you can read more on Sunshine UK if you want to. Many of you may have met me before. I am an NHS GP in Northamptonshire and have loved working with patients in group clinics, which we'll touch on briefly today, including those online. I've done some work with the RCGP and the Department of Health and Social Care on attitudes in primary care to obesity management, which I'll share with you. And I've got a number of qualifications in weight management, so a postgraduate diploma and a qualification in nutrition. I'm scope certified, and help deliver the Liva Momenta Paths to Remission, NHS Paths to Remission program, which is a rapid weight loss program. And I've just recently started a really exciting long process of applying for a grant with the Leeds Beckett Obesity Institute, looking at a food intervention for type 2 diabetes remission and weight loss. So that's enough about me. What are we going to talk about? Well, I want to start with talking about what I think we probably all agree, as you've shared already, we should all be doing to address obesity. What lifestyle medicines are already being delivered in NHS practice, despite being poorly funded and difficult to access, as you've shared with me. What is the actual evidence for lifestyle medicine interventions? A bit about what we're doing in the sort of medical education space. And then I want to really focus on the issues of food poverty and malnutrition and obesity, and what I'm worried this might mean for weight loss drugs and what I'm seeing in clinical practice, which I'll share with you. And then what I think we need to do to improve obesity treatment, whether we use these medicines or not. And then ending on some real practical tips about this concept of lifestyle medicine wraparound care. So this multi-component, individualized and person-centered obesity treatment. So to start, what should we all be doing to address obesity? Well, it's great to hear that one of the first comments was public health and policy. And of course, I haven't met anyone in the lifestyle medicine space who for 1 minute thinks that lifestyle medicine is the answer. No, it's public health and policy. And they are the most important, sustainable, equitable and effective interventions for both prevention and treatment, in fact, I think. And where that's failed and somebody ends up in our consulting room, then I think lifestyle medicine is very, very important and needs a level footing with the medicines and surgery options. But primarily, we should all be calling for more action to address these environmental, socioeconomic and commercial factors, because those are the most important drivers of obesity. So those include things like deprivation, living in a food desert, food insecurity, green-blue spaces, modern shift working, social isolation, screen use, sedentary behavior. You guys know all about this if you've done any work with us at the BSLM. And something that really worries me with the sort of focus on pills as a solution or drugs as a solution to our obesity crisis is that I'm worried about the factors at play that are influencing human appetite, because at the moment we have a number of large pharmaceutical companies creating these amazing drugs. And don't get me wrong, the results are, from trials anyway, are very clear that they do result in very significant weight loss through predominantly, I believe, appetite suppression. But we're getting into what I worry may actually be an arms race with the pharmaceutical companies creating medicines that suppress human appetite, whereas the food industry is very, very hard at work at the same time, trying to override those natural mechanisms that we have in our body to regulate our food intake. And I'm worried that we're going to get into this race and there are going to be a lot of losers, particularly financially, but also potentially in terms of health impact. And what I was a bit naive, I think, about the role of the food industry in creating foods that some would say now are hyperpalatable and even addictive. I perhaps thought this was by accident of design, but it's very interesting following the work of Chris Van Tollecken, who I'm sure many of you have heard of. And particularly, I'd recommend to you watching this BBC Two programme where he explores quite the techniques used in the food industry, and highlights the fact that these guys, they're very brilliant. They're doing an exceptionally good job. They've been employing food technologists, food scientists, using even functional MRI scanners on people who are eating way before perhaps the health care got involved and properly understood human appetite. And they've been doing this quite shamelessly. You know, once you pop, you can't stop. They know their foods have addictive properties, and we're only just catching up on this. So a really worrying trend of trying to override natural human appetite. And we're seeing the food industry responding to these new medicines, particularly over in America, creating foods targeted to people who are on these medicines. Now, that meal actually looks to me pretty good. I wasn't able to see the ingredient list, but I know that there are other products in this range which probably would not be considered to be balanced or healthy. And certainly the food industry in America is concerned about their profits having a dent in them by these medicines. So we are already seeing this sort of arms race. And there's lots of work been done studying the impact of these large food conglomerates on our health outcomes. And these are called the commercial determinants of health. There's a fabulous series in the Lancet here that is well worth reading about how these companies, including tobacco and alcohol and food, have serious impacts on our health, and we need to do a lot of work on them. There's so much work being done in the space now, though, and I can again highly recommend reading Henry Dimbleby's National Food Strategy. He's turned it in a book that's also incredibly readable, but the National Food Strategy is freely available online. And the Food Foundation is doing a lot of work in this space, as is Bite Back, supported by Jamie Oliver. I'm sure many of you have read Ultra Processed People, again written by Chris Van Tolken, who's an excellent communicator of science in this field. Over in America, I think they're quite further ahead than us. They're doing things like a Food is Medicine program at Tufts University. But coming back to the UK and Scotland, there's this concept now of potentially floating the idea of public diners. I didn't realise, but after the war, Churchill had pushed for things like public libraries and village halls, but also public diners, so people could have accessible and affordable healthy food. I just think what an amazing idea, where we could address social isolation and nutrition and the issue of poverty and access and skills required to make healthy food. I would absolutely get behind something like that. And we saw recently in the Darzi report this acknowledgement that we need to move to more prevention. We need to move out into community and more sort of policy and public health. So hopefully the tide is turning. And of course, there's us also in this space trying to improve the education of clinicians who are delivering care when policy and public health hasn't worked and people end up coming to see us. So that's what I think we really need to be prioritizing. But when we get into clinical practice and our patients have not got access to green blue space or healthy food and they're struggling with obesity, what do we need to be doing? Well, let's start with thinking about the general situation on the ground in terms of knowledge and attitudes to obesity. And this came from some of my work with the Department of Health and Social Care and the RCGP back a couple of years ago. And there's this general feeling, I think, certainly in community and primary care, that this obesity management is public health work being pushed onto general practice. And I absolutely get that, because we're having that in every sphere of medicine. It's all coming our way. And where's the additional funding for this work? There isn't any. The worries that are very valid that this could tip us over in terms of the need and demand out there. The general feeling that we've not been trained. And also that I won't repeat some really unfortunate, very out of date and even stigmatizing views that I think are important for us to acknowledge, that many people with obesity have experienced really rather unhelpful and stigmatizing beliefs from many of us in the healthcare system. And this really has to change. And I know there's a lot of good work being done now in this space, but it's very overdue. So as clinicians, we tend to focus on advising people or just telling people to restrict calories, reduce calories, and to exercise more. And on the whole, we don't feel confident to support people with obesity and to lose weight. And there's almost no education on obesity care still now. And I'm involved in medical education at Oxford University. And apart from my course, there really isn't enough done. And there's even less education on, obviously, lifestyle medicine issues, so nutrition, sleep, physical activity, social connection, and so on, which is why we need the BSLM and all the work that we do. So what are all the guidelines saying we should do, despite the fact that we're all a bit out of date and underconfident? Well, the NICE guidelines were updated in 2004 on managing overweight and obesity. It's very much framed around this ask, assess, advise, agree, assist approach, which many of you who have studied the behavioural science aspects of the core accreditation will already know about. It still focuses on this idea of just improving diet and reducing calories, a bit vague on the improving diet aspect, and this idea that we should, be encouraging people to be more active and refer people on. And if we look at what they're suggesting in terms of eating a nutritionally balanced diet, it's all framed around the Eat Well guide, which in practice I found isn't a great tool to help people when they're navigating our modern food environments. No one's plate actually looks like this. It has pictures of foods that really none of us probably should be eating, and no real idea of what moderation maybe is. And it also has pictures of cereals, which there's lots of evidence that may not be as helpful as we perhaps thought. But in principle, the main messages are pretty good in terms of lots of fruit and veg. I think there's some out-of-date ideas there, and it could do with being updated. So it's very focused on BMI as a measure, eating fewer calories and move more. And I think that's what we've all sort of heard and feel more confident with. I personally think that the Canadian weight management guidelines are much, much better. They're much more detailed in terms of specific nutritional counselling and behavioural interventions. And they move beyond this simplistic eat less, move more approach and actually start focusing on the root drivers of obesity. So I could highly recommend that as a guideline if you wanted to look it up. There's also the ESO framework, which again is looking at more than just BMI and this idea of adiposity-based chronic disease model, when we're actually looking at staging obesity and thinking about its health implications. There's lots of discussion about this at the moment in the literature, and this Nature publication about a new framework, which was very heartening because it would, yes, push this idea that BMI is only a surrogate marker, but really started to suggest that we should be looking at personalized goals rather than just a didactic advice, eat less, move more, and that we should be using nutritional therapy, stress reduction, and sleep improvement. It's the first time I've actually seen those in a suggested guideline, these more holistic markers than just eat less, move more, as the main cornerstones of obesity management. So things are moving. It's a very fast-paced field at the moment, but actually what have we got on the ground? Well, it really is quite simple still, isn't it? We have lifestyle medicine approaches, psychological therapies, medicines, and bariatric surgery. But as with many of you, I'm sure, on this webinar, access to this is extremely varied across areas and totally inadequate. And in terms of what's provided on the NHS, it feels like there's a degree of choice, but actually much of this is quite restricted. So the NHS Better Health website has some pretty good information. I think it could be more detailed and more up to date. Supposedly we have dietitian referrals, but certainly in my area, this is hugely restricted. Many of us now do have social prescribers and health coaches. I'm lucky to have access to a health coach with a nutrition background, and she's excellent. Some of us have activities, gym referrals, things like that on prescription. There's the obviously the type 2 diabetes path to remission program, which is for people with type 2 diabetes to help them lose weight. And there are tier 2 weight management services. But again, scrutinizing the content of that, it had very little, in fact, on dietary quality, which we're going to talk a bit more about. There's the NHS Healthier You, again, for people with a higher BMIs and supposedly tier 3 weight management. But of course, again, it's very patchy, completely inadequate. We have no prescriber in our local tier 3 area in Northamptonshire, or that may be changing. So they can't prescribe the new weight loss drugs. So very patchy, bit out of date. This is a fast-paced moving field. So let's move on to think about what's going on in the research and evidence space. So I think this is a really useful graph that is a summary of this systematic review and meta-analysis of weight loss trials back from 2007 now. But I think it really helps to frame where most of us are on our heads, and it gives a good summary. So I think we all know that exercise helps a bit, but that if we combine it with interventions around food, that it works better, and that diet alone actually is not as good. So actually diet and exercise did seem to be the right approach originally. And then we started to see meal replacements come in, which seemed to be a little bit more effective, but only sustained, obviously, while you have the meal replacements. Then we saw these very low energy diets, as we see with the NHS Paths to Remission, so the 12-week 800-calorie meal replacement, which again, really effective, but again, not sustained when you stop so well. And then we compare this to advice alone, which in fact, if you look at it, on average, all of us just gain weight over time, so it's not very effective. And then if we start to see these new weight loss drugs that coming in, I just put that on top, that's showing that they really show very effective weight loss. But of course, with any of these interventions, as soon as we stop because of the environmental pressures, the obesogenic environment we're in, we all tend to regain the weight at almost the same rate as you see with all those other interventions. But let's look a bit more about into these lifestyle interventions then. And this systematic review and meta-analysis of studies up to 2015 on weight loss interventions for obesity and cardiovascular risk did show this reduction in risk for mortality and cardiovascular disease and cancer. So they did seem to be effective. But if we look overall at primary care lifestyle interventions for weight loss, then really not very impressive at weight loss. So on average, after a year, you'd lose about 2 kilograms. What interested me is looking into detail into these trials is that they're very heterogeneous. So the interventions ranged from low cal to low fat to low carb, and we were really not clear over this period of time what exactly we needed to do around food to help people lose weight. And some of these trials now were very, very old, so back in the 1960s even. So I would suggest that these big systematic reviews are now out of date. And the area of nutrition science has really rapidly progressed since then. So I think that rather conservative view of weight loss maybe isn't reflective of what we might now be able to do. So let's move to talk about the rapid advances in nutrition. And I think we need to go over to Brazil here and just talk about some of the work that's been done there, where they saw this massive explosion in the urban population that around 2005, which coincided with a rapid increase in obesity prevalence. And I think for healthcare workers and researchers in Brazil, to them it was clear that the population's genes hadn't changed, and even markers of physical activity weren't particularly different. So something else had changed for people in Brazil. And this is what stimulated the work into looking more closely at the food environment and what had changed. And with this mass urbanization, they'd seen a huge amount of industrialized food. So this shift from traditional meals based on corn, for example, and beans to this packaged food. And they started to develop this scoring system, which I'm sure many of you know about, called the NOVA scoring system, which measures food in terms of how processed they are, from raw to minerally processed to processed foods, for which there is no harm associated with processed food, but this new category of food called ultra processed foods. And they tend to be branded, require multiple industrialized steps. They're not things we would normally find in our cupboard. So soft drinks, sweetened breakfast cereals, and so on. And once they developed this categorization system for these new foods that they saw that arrived around the time of this huge explosion in the rate of obesity in Brazil, this scoring system could now be used to more carefully study the effects of this type of food. And a real skeptic of this argument that food processing mattered was Kevin Hall, who ran this study in 2019 in a very closed control setting. So people even had to wear scrubs, so they didn't know if they were gaining or losing weight. I love that idea. And they provided all their meals over a 2-week period. And it's a very clever study because what they did is they matched the meals for calories, fiber, and macronutrients, so protein, carbohydrates, and fat. But one of the dietary patterns were ultra processed, and the other were whole food. And him and his team wanted to ask what impact did these foods have on weight if people were allowed to eat freely as much as they wanted. So what they found was those on this more ultra processed food diet ate 500 or so more calories a day and more carbs and fat and gained weight. And those on the more whole food diet ate fewer calories and carbs and fat and lost weight. So it seemed to suggest that these ultra processed foods could lead to weight gain. And certainly this has there's been further studies on it, sort of epidemiological studies, which of course don't prove causation, but suggest an association of these foods now. So there's now seen an association with ultra-processed food intake and cardiovascular disease risk, all-cause mortality, obesity, cancer risk. risk of COVID-19, poor perinatal outcomes, mental health issues. And this is a big problem for the UK, because if this is the case, we consume one of the highest proportions of household purchases of this sort of food group. And okay, the research is contested and in its early phases, and only a few trials now. But I'm very excited to see that this Kevin Hall's work is going to be replicated with the update trial at King's College in London by Samuel Dickin and his team, to ask if these ultra-processed foods versus minerally processed diets affect people's weight and other health outcomes. So what's really interesting is they're actually going to look at people whose diets were already high in ultra-processed foods. And I think what really gets me about some of the lifestyle intervention in trials is that they're done in a blanket fashion. And so people are given food interventions when perhaps it wasn't food that was necessarily driving their obesity, and there was nothing more they could do to improve their diet. But they are people who really, for whom this is likely to be a problem. And so they would see a change if it was that issue. They're going to have 8 weeks on this ultra-processed food diet, and then a minimally processed diet washout, and it'll all be provided. And they're looking at various different outcomes. And Samuel's going to be able to hopefully present some of the findings from this at our conference. So do join us in Brighton this September if you want to hear more about that. I think it's going to be very exciting. So let's just summarize this change in this research focus and consensus from this reductionist view of food to more complex systems. So back in the 1900s, it was the first time we discovered the vital amine, I think it was thiamine, and this idea of vitamins being needed and being part of our food. We then started to understand a bit more about carbs and fats and proteins, so these macronutrients. And then we started to see dietary guidelines coming in, often quite heavily politically focused, for example, around sort of corn surpluses in the US. And then we've, in the 2000s, 2010, understood more about food and dietary patterns, and evidence around Mediterranean dietary pattern being associated with improved health outcomes. And this idea that you could have this double burden of malnutrition, i.e. malnutrition in obesity. And then bringing us up to closer to today, explosion in understanding around the gut microbiome and the need for fiber and food structure to arrive in our lower gut for our gut microbes to digest and release the nutrients we need. More work done around this NOVA classification, this idea that quality of food seems to matter just as much as quantity, i.e. calories. And then this concept of phytonutrients, so these bioactive chemicals in particularly plant foods. And this means that our current labeling systems and guidelines, which are very based on macronutrients, really are probably out of date and not very helpful. And so if you look at these food labels and the one in the red compared to the one in the green square, you'd be forgiven for thinking, if you were in our current food environment trying to work out, are the foods on the left healthy and are the foods on the right unhealthy? You'd be forgiven for thinking the ones on the left were unhealthy, when I think most of us would feel that actually those are healthy foods, when most of on the right are unhealthy foods. So you can see how this reductionist approach to just calories and macronutrients and micronutrients hasn't really helped us in this new food jungle. So at the same time, I think it's really interesting, we've had this shift in focus and understanding about what causes obesity, again, from this reductionist genetic approach to a more complex systems approach. Now, I don't know about you, but in the 1980s, it was very much genes are our destiny. And this came from this discovery of the DNA double helix, DNA sequencing techniques, and this big human genome project. But I don't know about you, but I know genomic medicine is exciting, and there have been some really lovely designer drugs. But in terms of real impact on the ground, certainly in the community, I've not really seen as many of the benefits that perhaps were touted at the time. And now we understand that many lifestyle factors such as stress and sleep and exposure to green spaces and so on can up and down regulate the expression of our genes through epigenetic mechanisms. And that we now have this global medical discipline of lifestyle medicine. So there's been this sort of improvement in understanding about lifestyle factors and nutrition going on in the background. That means that much of what we're doing in this space in research is probably out of date. Now let's start to talk about anti-obesity medicines, because that's the real hot topic here, isn't it? So again, massive explosion of research. It feels like every day there's something new going on, and there's even more newer drugs in the pipeline. But I want to talk to you not about how these medicines work, particularly because there are many others who do that better than me. I want to talk to you about what I'm seeing on the ground. So these are a couple of real life cases, not their real pictures, but they have given me permission to share their details. So this lady was middle-aged with many of the illnesses that we see in people with obesity. So depression, fibromyalgia, type 2 diabetes, and so on, and also on many medicines. So before she started Wegovy, this was the food she was eating. And it's amazing. I ask people a lot now about what they're eating and how many of us eat the same types of food every day, because she had a frozen meal in the evening, very busy mum, job to juggle. And now she's on Wegovy. This is what she was eating. And I think most of us hopefully could see that this diet is very low in fiber. It's probably not giving her what she needs. It's probably too high in sugar, but it was probably in her mind the sort of low fat, low cal diet that she'd maybe heard advised. Another case of a younger person with lots of mood issues, actually came in with bleeding gums and ulcers on her lips, wanted the weight loss jab. I was excited because she was telling me she was a vegan. I thought maybe she was eating loads of veg. No, Dr. Fallows, I don't eat any vegetables. This is what she was eating. Again, quite similar foods every day. And when I did very basic nutrient tests on her, she was very low in B12, vitamin D, folate, and iron. And I wonder that she had scurvy. Of course, vitamin C is a photo unstable vitamin, so we can't actually test out in the community for it. But I wonder if that's what her bleeding gums were. Another lady just a couple of weeks ago, Dr. Fallows, it's food or the drugs. She was buying Mounjaro privately. She was telling me I can afford the drugs if I don't buy food. If I take the drugs, I don't need to buy food. And therefore, she actually was telling me she was saving money because she wasn't having to buy food. And she was living on literally a slice of pizza and 2 cups of sugary tea a day, which was a reduction of what she was eating before, which is, again, mainly pizza and tea. Now, this made me think, goodness, what studies have actually been done on people who take these medicines? So I looked at the literature and the current trial definition of intensive lifestyle interventions. And I wouldn't really call these intensive personally. That's 8 dietitian appointments over 3 months where people were counseled on behavior modification strategies, had a 3-day diet log. And again, very focused on reduced calories and exercise, and really no mention on the quality of food. And these were in the big Surmount trials on Mounjaro. And then I looked further in this review. There were a couple of reviews done about research in this space, about the food that people actually eat on these medicines. And it was quite remarkable. Even these researchers, for example, stated they were very shocked that there is no research on what is being eaten by people treated with anti-obesity medicines in real-world settings or even in trial settings. So, okay, we're measuring that there's a reduction in calorie intake and we're seeing the BMI drop, but no one is asking what were they eating before, during treatment, and after, or what was their nutritional status before, during, and after. And why do I think this is a problem? Well, because I think we've got a problem with malnutrition. So malnutrition in the UK is on the rise. So these are not great quality data, but it's data from hospitals around deaths involving malnutrition. And they haven't really shared the scoring systems they were using for malnutrition. And of course, many malnutrition scoring systems, one of the points is weight loss or underweight, where actually we know that you can have malnutrition even at overweight BMI ranges. But that aside, it's rising. It's an issue. We're seeing rising rates of admission for scurvy, severe protein energy malnutrition in pregnancy, rickets, and so on. And this is because we're seeing rising rates of food poverty in the UK. And I think this brings us nicely to the idea that we need to talk more about this concept of malnutrition in obesity. So we mean muscle wasting, vitamin deficiencies, mineral deficiencies, and microbiome disturbances. And we're seeing this because we are consuming more low nutrient foods, and that this diet is increasing the prevalence of malnutrition and nutritional deficiencies despite our high calorie intake. This is quite a difficult thing to get our heads around, but beautifully described in this paper. So how big is this problem? Well, I don't think we're doing enough work to look into this, but certainly a well-studied population are those who are about to undergo bariatric surgery. And we know that over half of them also are malnourished by whatever scores they decide to be using. And prior to surgery, over 80% of people have more than one micronutrient deficiencies, and over half have two deficiencies. Sarcopenia, so muscle wasting in obesity, is harder to study. Again, we don't have consensus here about what we mean by sarcopenia. And in some studies, 100% of people with obesity have sarcopenia, but it's very challenging to measure. But the point I want to get across, that's beautifully represented by this piece of work, is that malnutrition is as prevalent in obese and overweight weight ranges as it is in underweight ranges if you're looking at certain scores. So this Cronut score is a very good one. And the point that this team were trying to make is that malnutrition is an independent risk factor for major adverse cardiac events and all-cause mortality independent of BMI. So here you see after all-cause mortality after adjustment for sex, BMI, and other risk factors goes up as you become more malnourished. And this is well understood in global data. So this is the Lancet Global Burden of Diseases study. The number one driver for the global burden of diseases is malnutrition, above air pollution, blood pressure, and smoking, for example, and other dietary risks and obesity. And why might this be the case? Well, we think it's because people with obesity have gut inflammation, they have disturbances in their microbiome, they have the difficulty to store it, they may not be eating the right foods that have all these things in. And also that we prescribe them medicines that prevent absorption of particular nutrients. So when we're thinking about the impact of these drugs on intake that result in just lower intake of poorer quality foods, I think we really need to be on the lookout for issues of malnutrition. But what worries me is that it seems to be very hard to pick up from the yellow card MHRA adverse event reporting system that we have in the UK for these new medicines. There are a few being picked up here, and again here with semaglutide, but it's very difficult. I can't find any headings for malnutrition, and I wonder that most of us are not aware that this is an issue and know how to pick it up. But worryingly, there have been 4 case studies in the US now of semaglutide leading to Wernicke's encephalopathy, which many of you may have seen in people with alcoholism and is as a result of critically low levels of thiamine. And if untreated and undetected, can lead to a permanent dementia syndrome. And a couple of these cases were in otherwise young, relatively fit adults. So this is a serious problem, and I worry it's going undetected. But I'm not the only one to sort of raise the alarm that we need to be supporting people better who are on these medicines. Vicky Price here, the president-elect of the Society for Acute Medicine, is saying she's in a just recently published article. They're very concerned about the number of people attending A&E, and she would call for using these medicines as part of a supported weight loss program. And we're also calling for this. You may have recently seen our joint consensus statement with the College of Medicine and the British Association for Nutrition and Lifestyle Medicine, where we're asking for policymakers and public health teams and generally in healthcare for us to be supporting a lifestyle medicine wraparound. So how do we improve obesity treatment with these medicines? Well, I think we need to be raising awareness of this idea of malnutrition and obesity amongst the public as well as clinicians, that we need to get people to commission lifestyle medicine wraparound, so this multi-component personalized intervention that assesses all these things. So I just want to wrap up and finish on what do we mean by lifestyle medicine in obesity care. Well, this is what we mean by lifestyle medicine practice, that we want people to assess social determinants, use skills to support people, and address all these lifestyle medicine pillars. And we've talked a bit already about food, but I think when we were in really constrained time appointments, like many of you will be on this call, that we perhaps start with conversations around breakfast. And I find in my own practice, this is often an area where we can make some quick wins. And in terms of talking to people about improving the quality of that meal, if they even want to have it at all. I think there's been a lot of marketing in this area, a lot of confusion and misunderstanding, and we can help many people to move to more whole food patterns. I think we should also be talking about food timing, many of the people I see are eating all day long, way into the evening and nighttime, and just this concept that our gut needs some time to rest, and this evidence that this time-restricted feeding or even intermittent fasting is both safe and has been shown in some studies to improve metabolic health. I want to touch briefly on physical activity because despite the fact that there's robust evidence for wide-ranging health benefits and that physical activity preserves fat mass during weight loss, which is so important with these new medicines, and it may promote weight maintenance, there's actually very little evidence, as I showed you before on that graph, that physical activity, particularly alone, has much effect at all on weight loss. And there's some interesting studies, only in rodents, but coming out to suggest that really vigorous exercise, maybe particularly for people who are very unfit, could lead to weight gain through stress-related mechanisms. And I do worry about injury for some people who actually need a more supported program. And I'd urge you to look up some of the work of Herman Ponzer. So this is by no means has a consensus behind it and is just a one theory, but I think is very interesting and speaks to a lot of the experience my patients have of when they do physical activity. So Herman Ponzer's team went out to the hunter-gatherers and looked at traditional farmers who are very, very active. So they're the blue and the red dots in this graph. And he did this sort of gold standard measurements of total energy expenditure using radio-labeled water, I think, and compared this to the total energy expenditure of people like you and I probably do desk jobs and are relatively inactive in comparison, and found that actually the amount of our total energy expenditure is very similar and only really dependent on our fat-free mass, i.e. muscle mass. And he goes on to explain, if you wanted to read in his book called Burn, and he's given a number of talks on this, that this constrained energy hypothesis that really means we can't run off excess calories very well. And that's because if you think of this pie chart as the entire amount of calories we burn, or that our total energy expenditure, that most of them, if we're sedentary, are spent on physiological processes, so running our body. And that if we're more active, so we increase the proportion of the amount of energy we have to extend on physical activity, what happens in our body is that we down-regulate physiological processes in order to conserve energy. And the most energy consuming process in our body actually is our immune system. So what we see is this downregulation in immune activity, which may be one of the main reasons why physical activity is so good for us. We see it turning off that chronic inflammation that we know drives long-term conditions. So this speaks to the fact that many of my patients say to me, look, I've caned it out of the gym and I'm not seeing any improvements in weight loss, even though I might feel better, for example. So I'm not saying that physical activity isn't important, but I think we've overemphasized it potentially in the weight loss space. And certainly in the Path to Remission program, during the rapid weight loss phase, the advice is not to increase your physical activity, but to maintain it where you are until you've stopped rapidly losing weight. And then we support people to gradually increase activity. So very interesting approaches now. I think sleep is really not given the attention it deserves. And for some people that I meet who are eating perfect diets, who are very physically active, often shift workers who are doing thousands of steps a day on the wards, for example, they're eating when they should otherwise be asleep. And I think this we need to have more research done. But what we do know is that short sleep and poor quality sleep and shift work, for example, is associated with increase in appetite and with obesity. But what you and I really want to know is, can we do anything about it? Certainly, I think we need more work. There's a little bit of work done in children. But again, it's been rather poor quality, where the good quality study did show some weight loss actually for children. It's a surprise, again, that the main gold standard intervention for insomnia, for example, CBTI, there's been no studies on it for weight loss. I would love to see them. And there's some interventions to improve quality and on sleep extension with some marginal impacts. But I think for some groups, particularly perimenopausal women, which is where HRT may actually be quite beneficial, for example, this may be quite a significant driver of obesity. Social connection is a big one that we talk a lot about in lifestyle medicine, because it's a major driver, social isolation of ill health. And again, not enough work in this space, but I do wonder that the evidence there is suggests that we should be doing more work. So the onset of obesity in men is associated with an increase in loneliness. And of course, that could be bidirectional. And that social isolation in rodent models certainly has been associated with really significant weight gain and increased food intake, which is very interesting and suggests we need to do more. And there's certainly evidence that psychosocial stress is associated with obesity. And I think for some of my patients, it comes as really, really great news that actually, rather than running on a treadmill for hours on end, actually their yoga, their massage therapy, their time walking in a forest or doing mindfulness-based techniques, there is evidence that these can help people to shift weight, certainly by addressing potentially the stress hormones. But again, we need more work. So I think rather than this very impersonal, eat less, move more only approach, we should be more person-centered and try and help you with specific food swaps, social connections, sleep interventions, stress reduction, some activity. And haven't got time today to talk about stopping pills, but we give people so many medicines that cause significant weight gain, many of which can be stopped if you're helping them with the primary drivers, insulin, for example, and so on. So why aren't we doing this? Well, talking about lifestyle is difficult, isn't it? It's tied up with our identity and culture. There's ideas of blame, significant issues with affordability, particularly around food. And for us, there's a lack of training till the BSLM came along. We're a bit confused about what's going on. We think somebody else is doing it. They often do not, and we all lack time. So now to close, I'm just going to share with you some tips from what I've learned from my practice. So I'm not talking about if you were in a weight management clinic where you've got maybe an hour, but I'm talking about if you've got 10 minutes as an exhausted GP or hospital doctor with many other issues to cover. We really have to take an empathic listening coaching approach. So this is so important that we reflect back, we use open questions, we ask that dreaded if anything else, but actually asking if there's anything else can really help get to the nub of the problem very quickly and avoid you doing things that are just not going to work for the person. Asking people what matters most to you right now about your health, and then trying to make these lifestyle pillars inquiry routine. Just trip them off after you've asked, do you smoke or drink alcohol? What did you eat yesterday? When did you last eat a green leafy vegetable? How is your sleep? So these sort of screening questions, which as a BSLM member, you've got access to these sorts of questionnaires, which you can even share by text beforehand, for example. We must deal with people's priorities first. So if they come about knee pain, you've got to deal with the knee pain and offer them medicines if they want them. And then you can ask permission to maybe take a different tack. Did you know, I've had patients like you with knee pain who, when we explored all the other factors, were more interested in talking about food and sleep and how that might affect their pain than they were about medicines and surgery. And if it isn't the right time, back off, just keep the door open. So the kind of modified 5 A's approach I take is to ask, rather than ask permission to talk about obesity, is actually to talk about the root drivers and the ones that matter to the person. So what matters most to you right now about your health? I'm going to keep banging on about that because I think it's so important to assess all those socioeconomic factors, financial stress, lifestyle medicine pillars, and then assist people in agreeing what kind of supportive, personalized, multi-component lifestyle medicine approach might help. So let's take some quick examples. What matters most to you about your health right now? People with obesity often say they are tired and hungry. And isn't that remarkable when it's a disease of excess energy storage? Something's going dreadfully wrong about the systems in their body, isn't it, to mean that they often feel like that? So these are often the things that I hear, not always that people actually want to lose weight, but it's these other things that often matter a little bit more. And then you can reflect back to try and explore what it is they want to do. And then you try and take a brief screener on these aspects and then deep dive into areas that you might think sound like they're maybe key drivers. So for some people, this might be poor sleep and inactivity, but others, it might actually be food or excess time on social media, which is driving them not to sleep and so on. And then you've got to ask them where they want to start with all this. What do you think is the most important thing I could help you with? Now, we've talked through all of this, what matters most to you, and then seeing if they can come up with ideas about where they might start. And then you can start doing things like referring on to other people. So you don't have to do it all in your 10 to 15 minutes. Hopefully, most of us have a team now. We need to reach out to them as well. So this is the brief approach that I take, but of course I can still hear you saying that's still too much time. I don't have enough time for that. So this is where group consultations work really well. Don't have enough time to talk about that today, but loads on the BSLM website, and I absolutely love them. So to wrap up, if you want to hear more about this lifestyle medicine approach, I'm delighted to let you know, finally, we are on the cusp of publishing the first UK textbook on lifestyle medicine, with a fabulous group at Imperial College and many members of the BSLM who've contributed to this very practical manual. Lots of others from Australia and America as well, of course, available. These are some of my favourite books. Brilliant one by Michael Marmot about the social and economic drivers of ill health. Fabulous one by Ted Dinan on the role of food and mental health and mood, which causes key issues for people, often with people with obesity. And again, Professor Felice Jacker in the same space. If you want to learn more and get an accreditation, then the BSLM core accreditation will cover this approach. We're shortly to be releasing, Kate Willie and her team, the BSLM Obesity and Weight Management course. And I've mentioned these other resources throughout the talk, the Canadian Obesity Guidelines Scope and the National Food Strategy. And do come and join us in September. We're going to have a panel discussion about this hot topic of weight management in the lifestyle medicine space. It's going to be really brilliant. I'll be very excited to see you. I'm going to finish on this quote that I always love. I think many of us worry that our patients don't want or have the resources to be able to change. But actually, I think the biggest challenge is getting us to change our approach in consultations, to bring in more options for people than just pills and surgery. And that's changing our mindset. And Lord Nigel Crisp, ex-health minister, has written this book called Health is Made at Home and Hospitals Are for Repairs, with lots of good real life examples of where this has been possible. So good luck to you all. I hope you're still with me because it's been quite a long talk. Very happy to take questions.
Thanks. Hi, Ellen. Thanks for that. Oh, I've got some light coming in my screen here. Thanks so much. We haven't got any questions coming through, or there's one coming through now. Let's have a look. From Anna, could the lack of evidence for activity for weight loss be because the amount of exercise is too small? Most people I know, she's an endurance runner who does a larger amount of exercise, are not overweight despite eating a lot. Many of us actually struggle to get enough calories to prevent the low energy availability.
Yes, I think it could well be that. And I think, many of the people we see, and even, myself, if we're working and we have desk jobs, it's very, very hard to do the levels of activity that are required to burn off the type of calorie dense foods that we are surrounded by. But like I've shared, I'm very interested in that piece of work suggesting that much of the response to increased physical activity is to downregulate our energy requirements. So it kind of gets harder the more active you are to burn off, or in a sense, it is unlikely that we can suggest to people that you can burn off excess calories too easily. But the nuances around endurance running, I think that's difficult. I can't say I know enough about that to know whether we should all be doing endurance running, but I suspect most of us can't do that.
And actually, maybe that's a good point. How important is it to meet people where they are? And, it's not all about necessarily endurance running. A lot of what we're seeing on a day-to-day basis is people that struggle to perhaps make a lap around the kitchen or around the lounge. And so in framing it, you touched on some of those elements, but how important is that?
That's such a good point, Emma. And I know you know well our approach to this isn't it? It's very personalized. And this is the whole point with lifestyle medicine, is rather than just telling people to eat less, move more, it's about assessing what are they currently doing, what actually matters to them, what might they be able to do realistically, considering their work and their family commitments and so on. And like I said, I've met people who genuinely, I believe that they're meeting the current recommendations for physical activity, and despite that, are struggling with obesity. And for those people, it seems to be other factors that are driving their weight issues, whether that's prescribed medicines or eating at nighttime or high levels of stress. And for them, it comes as really, really good news that actually managing their stress, or helping them with things like yoga and mindfulness-based stress reduction and sleep improvement, may have just as an important role as trying to increase their step count or whatever it might be. So I think that personalized approach is very important.
Thank you. Also, Hussein's just mentioned in the chat there as well. Thanks for that, Hussein, around group consultations. I know Emma's going to pop a couple of links into the chat as well. But how effective have you found group consultations for weight management support?
Hi, Hussein. Yeah, thanks for that question. Yeah, I love to talk about group clinics. I don't think there's been enough work done. It's not a well-studied area. I think at the moment it's hard to deliver any types of primary care interventions, let alone set up group clinics. So to those of you who are managing to do so, well done. And if you can get some data, please do. In the groups that I ran in Bicester for metabolic health, I did see some remarkable weight loss stories. And I think this is because you can give this more longitudinal approach. You've got more time to give a personalized approach and hear from people about what really it might be that is driving weight for them. And it really draws on that support from the community and other people around them. And it's so wonderful to see people sharing, or did you know there's this park run, or did you know that I've found this shop where you can get cheap lentils, or whatever it might be that people are sharing. These real practical steps that are needed when you support people with lifestyle options.
Thank you. Apologies, the beautiful sun coming in here keeps playing with havoc with my camera, so apologies for that. Thanks so much. We've got a couple more questions coming in. Ellen, what is your experience of how much proper diet or exercise advice private pharmacies are currently offering for when these therapies are prescribed?
I would say on the whole, and I do work in an area where we've audited and found that we've got over 100 patients prescribed them privately, and I'm actually running an audit with patients with some students of mine at the moment to assess what support they've had and actually their dietary quality. So I'll be able to answer that question in a lot more detail shortly, but overall it really is not enough. Even in the best quality providers, it's often just a link, and I often find that many of my patients haven't clicked on it yet. Or a piece of paper or nothing at all. So this is why I am so worried about this issue of malnutrition in obesity. And I've seen a couple of people lose significant weight and feel dreadful. And I suspect it's related to the fact that they probably now have significant nutritional deficiencies. I'm actually struggling to get people to come back to have blood tests. And I think it's because to pick up these and prove these nutritional deficiencies, I think it's because people are worried I'm going to stop their medicines, which I'm not. Look, I'm not against these medicines at all. I use them. I plan to use them. I see them as a behavior change support or an adjunct to this approach. But I think they do have risks if you don't support people to access these foods. And I'm particularly worried if they're targeted at more deprived populations who may not be able to access healthy food at all. I suspect people in those groups need even food on prescription, for example, as we're seeing being used in the US.
Thank you. Any advice on how to guide patients around the risk of intermittent fasting and reduced calorie intake whilst on these medications and the risk of muscle loss? Rishi had a diabetic patient yesterday saying that they ate McDonald's only because they knew that they had to eat, even though they really didn't have the appetite and weren't wanting to. So how can we advise on the risks around that?
Yeah, it's a great case. And I'm sure many on this webinar will have had similar experiences, met people who are on a severely restricted diet. And what really strikes me is that with the Paths to Remission program, it was limited to the under 65-year-olds, and it acknowledged that if you're on an under 800 calorie diet, as you have to be to lose weight on this program, it's difficult to meet your protein and mineral and vitamin requirements. And so they gave people total diet replacement. And to be sure, people were getting their total dietary needs despite being under 800 calories. So why we've thought that people on Mount Jaro, which I'm seeing in clinical practice, reducing their intake to nearly maybe 200 or 300 calories a day, wouldn't need that same support is remarkable. It seems very odd not thinking. So I think in terms of guiding people, it's difficult, isn't it? Because there's a plethora of different dietary organizations, some very linked with the food industry, some not. And I know that at the BSLM, that's our one of our top priorities, isn't it, Emma, to try and get some good guidelines out there for you guys to be able to share with your patients, because it just isn't detailed enough on the NHS websites, and there certainly isn't enough around this specific risk of malnutrition on these medicines. So I think it's a big area of need, but I agree there is no one destination yet to go for good quality advice for patients, but don't worry, we are working on it.
Thank you. Where are you signposting patients for protein targets, especially as their intake decreases on these meds?
Yeah, so really good question. And there's a lot of, this is another hot topic, isn't it? Protein requirements. And there is, there are various formulas, aren't there, per weight and so on. I think, again, people in real life, we don't tend to want to weigh our food all the time. We don't eat protein on its own. Most of the time it's mixed in with a meal, isn't it? Unless you're following particular types of diets. So I think it's difficult, isn't it? It's very difficult to give people good guides. And again, we lack a sort of single destination to point people to. But you would hope that the prescribers are ensuring that people are getting this sort of advice. But the advice that I've seen is not often very practical. We need more visual guides. So it's an area that I think we just don't have good quality resources that we can trust and we're able to share with patients. But this is something on our priority list.
Right. There's a huge number of patients being prescribed Manjaro privately, thinking about group sessions to discuss lifestyle medicine to avoid having slim and unhealthy patients. Any quick tips?
We have lots of quick tips, don't we, Emma, on our website. If you become a member, we have lots of resources for you, great sort of business plans that you might need to take to your partners or your practice manager or your trust. Also lots of templates, the NHS e-learning for health modules for group clinics are free. I help to write them if you have an NHS mail email address, and that again has all the different performers you might need to have. I think us as clinicians, we get very tied up and worried about confidentiality issues. It's amazing how patients, once they understand what these are and come along, really are not worried about that and really enjoy feeling validated by their peers and emboldened by them. So my top tip would be just get on with it with any willing patients in order to grow your confidence. I think when I started out, I was too picky about saying, I only want people on insulin and this age and that. You should just go with initially those people who want to work that way so that you can gain experience and start to enjoy it. So I would say crack on with it and use the resources from the BSLM and the NHS e-learning for health.
Thank you. I'm conscious of time. We've got 3 questions remaining, and we'll see if we can get through those as quickly as possible. We've got one saying they're meeting their local rep about trying to get diabetic group consults off the ground in their practice. How could they be encouraging the representative themselves and these bodies to be able to support lifestyle medicine? Is it research? Is it by funding? Is it group consultations? I know we're particularly cautious about taking any funding from pharmaceuticals, but is there any ways that we could still get them to be more responsible?
Yeah, well, one of the ways is coming and joining us at the BSLM, attending our conferences and helping us to become stronger in this space so we can influence policy, public health, and ensure that the voice of those who understand the evidence base in this field are heard. So that's the first thing you can do. Secondly, I totally understand the practical issues of trying to get anything done at the coalface. There is no money anywhere, in my experience. And so what often helps when you're talking to people who you might want to give you money, particularly in the NHS, so if you're talking to your local ICB or trust, is to discuss end-of-year cost savings. So at the moment, it's very difficult to sell the concept of prevention because you can't prove that you prevented something. There isn't a nice number you can give to somebody, whereas you can do that for things like reduced attendance, reduced admission, and stopping medicines. And the wonderful thing, as many of you know, with lifestyle medicine is for some people with the right support, you can address the underlying factors for many long-term conditions and get people off medicines. Now, patients desperately want, on the whole, to come off insulin. It's a terrible medicine. It makes them gain a lot of weight. It's hugely burdensome, painful, unpleasant, risky. And it's very costly. So if you could deliver an intervention that could help people get off insulin, you can immediately show thousands of pounds a person of cost savings in that year, and you can prove that was the case because you stopped their prescription. So if you wanted an area to start where you could demonstrate end of year cost savings, that's one of them to go for. As for the nuances of, should we or shouldn't we take money from pharma or tech or any of these other industries, it's very, very difficult, isn't it? Because at the moment, and I see this in many of the meetings that I'm in, they do have undue influence. I'm not saying they're bad or good. I don't think it's as binary as that. These are important medicines. I think it's very difficult. It's very difficult to be able to then run something without feeling that you have any bias. And then it's very difficult to get your results looked at and understood in an unbiased fashion. So it would definitely introduce significant conflicts of interest, would make it difficult for you to then share or publish your piece of research. So it's a minefield, very difficult area. We could spend a lot of time talking about this, but I hope those thoughts are helpful.
Thank you. Absolutely. Any harm in prescribing thiamine supplements for people on these meds?
Yeah, I think it's a good question. And I think we need more work looking at whether or not multivitamins might help. I mean, unfortunately, most of the studies into multivitamins have shown that actually we think they should have in them, and they may even have things in them that are harmful for us. And then secondly, of what poor quality research that's been done in this area, the little we have suggests that they're not associated with improved health outcomes, and even some studies have suggested poorer health outcomes in people who are taking multivitamins. And I think it's again harking back to that over reductionist view of what good quality dietary patterns are, this idea that it is just the vitamins and that will sort it. Well, I don't think that's an evidence-based approach. I think we need trials that look at nutritional status before, during, and after these medicines, and the impact of multivitamins if they are sufficient. But of course, multivitamins don't have any of the phytonutrients that fruit and veg have in. They don't have any fiber in them, certainly don't often contain omega-3, for example, or protein. So I think that's an over-reductive view. I would much prefer people were getting good quality support for whole food dietary patterns of whatever was their preference than we just stuck them on some multivits. But in resource and time poor settings where we haven't got the evidence, could this reduce risk? Probably.
Thanks. And ending on our last one, a very important point. Sagal gives talks to about lifestyle medicine at schools and community centres. And she's asking, when she asks them what support they need to be healthier, they're often saying more education and more information about how to do it, but never mention economic problems. So do you think that we can make this advice more cultural, or the support more cultural? And sometimes I think she's saying quite rightly, we assume the reason behind why people aren't living a healthier life, and so focus on the wrong determinants at times.
Yes, absolutely. And I think if we had more time, we could explore with our patients what maybe was driving if say it was food that was a big issue for them. And it can be multifactorial, can't it? I've just come from a patient engagement event for this research that I'm doing with Leeds Beckett, and the variety of different reasons people were quoting for why they struggled with what they felt was following a poor quality diet. It shows again the need to personalize this. You can't just give somebody a handout. We need to be asking, okay, is it financial issues? Is it that you've got one person today was telling me they have too much pain in their hands, they can't prepare healthy food, or they have to prepare food for a very sick relative who needed a completely different diet and they just didn't have enough time or energy. There's loads of different reasons why, and we need to be assessing those reasons and then providing that personalized support. And you're absolutely spot on around the need for culturally specific advice. You know, for example, in the Paths to Remission program with Memento and Liver, we have really, really brilliant different kind of food and recipes for different groups, as we deliver in Birmingham, Solihull, where there's many Asian ethnic groups. So we've got a lot of really specific resources. But of course, this takes time and money, and there is not enough in this space. So a huge challenge, but it's really great to hear that you're out there talking to kids, because that's where we need to start, isn't it?
Absolutely. Thank you very much. Thanks very much to Ellen for leading the talk today, and thank you to each and every one of you for joining us. This recording will be available open and free to all on our website, so we'll send you all out a link to that. But please do share it far and wide. It's been amazing to see the breadth of multidisciplinary teams joining us today, and the more that we're connected and all singing from the same hymn sheet, the bigger the difference we can make. So feel free to share a link. There'll be plenty of open resources on our website. We just did a workforce first study day on how lifestyle medicine can help our NHS workforce and fighting all the day-to-day pressures that you're facing. Please feel free to share those far and wide, and if there's anything we can help you with, please do get in touch with the office. Thanks very much for your time. Thanks, everyone.
Thank you. Goodbye.
Bye.